Good afternoon, class. So basically today we are going to study about the radius bone. Okay. Now basically to describe any bone, like whichever is in pairs, like the ribs bone, the hip bone, the scapula, clavicle, and the upper limb and the lower limb bones, we need to determine the site. This is the basic funda. Okay. So like to determine the site, like first of all, you will be like in an exam you will be given these bones and you need to pick one, or you will be asked to pick the radius. Now if you pick the radius, you need to determine which side it is, like this. So for this we need to know the anatomical position of the bone. So basically it is a long bone of the forearm and it is homologous with our tibia. Tibia presents in the lower limb. Okay. So this presents laterally, like this is our forearm, this is our arm. Okay. So in upper limb we are having arm, forearm, and this is basically the wrist and we call it hand. So basically in the forearm we usually get the pulse here, radial pulse. So this is the radius. This bone is the radius, and the radial nerve that comes here goes through this side, and just along with it we also getting the radial artery. So basically the pulse that we usually tell about, so this is basically the radial pulse which we get here. So now to describe this bone, so basically the radius has three parts. This is the upper end, this is the shaft, and this is the lower end. Now the upper end has some features, the shaft has a few features, and the lower end has the maximum number of features in the case of radius. And there are certain ossification centers also we will see. Now how to determine the site? So basically this is the right radius, and the radius I am having is the left one. So how to know which one is the right and which one is the left? There is a simple trick which I will tell you later on, but before that, this is the left radius, because first of all identify the radial tuberosity. This is the radial tuberosity. This one is the radial tuberosity, and from this one an anterior border will come which will be like this fashion. This is an oblique line, na? So this will be like this fashion. It will come downwards and it will go down. So here also you will see this is the styloid process. So this is the styloid process, and this is the anterior border which is coming downwards. So the how to determine the anatomical position is that we need to see the styloid process. It will be always present medially, like this is the medial side, this is the lateral side, and then we need to see the styloid process. This is the styloid process, so we need to see that it should point laterally. Okay. Now we need to see the medial interosseous border, which is this one. This sharp border is known as the medial interosseous border. Okay, so we need to see whether it is facing medially or laterally. Now since it is facing medially, we are having the radial tuberosity facing medially and the styloid process facing laterally. This is the left radius. Okay, this is radius of left hand. This is basically the anatomical position. You know, na? This is not anatomical position. This is anatomical position. So this is our left hand radius. Now the simple thing is that in exam how to identify. So basically whenever you will pick a radius, you will see in the bottom end there is a smooth part. First of all identify the radial tuberosity, that much you need to identify, and after that see this smooth part. So the smooth part will always face front. Okay, and behind it there is a rough part which will always be in the posterior position. So in this way you don't need to tell this to the examiner, but to the examiner you need to define it like that, as I have explained. But for your identification you just need to see this rough part which will be posterior and this smooth part which will be anterior. Okay, so this is the right radius. Here we will see the head. This smooth part, this is the area for the capitulum. Capitulum of what? Capitulum of what? Humerus. And this is the radial tuberosity, where we'll see that a very important muscle inserts, that is the biceps brachii. And this is the anterior border. This one is the anterior border. Okay, and this is the sharp interosseous border. This one is the sharp interosseous border. And this is the posterior border, this part. So anterior border, interosseous border, and there is a posterior border. Okay, see this thing. This is the posterior border. Okay. Now between the anterior border and the interosseous border, this surface, like this surface, this one is the anterior surface. Okay. And this part, this is the lateral surface, and between interosseous and posterior we are having the posterior surface, anterior, posterior and lateral. Okay. Now as I have said you, side determination. Superiorly there will be head of the radius, medially there is the sharp interosseous border, and anteriorly there is a concavity at the lower end, this concavity. Okay, concavity, no, not this one, this concavity, see. This will be in the lower end. Now anatomical position, it is placed vertically in the body, and it has three parts as I have said, upper end, shaft and lower end. Now the upper end, this bears a disc shaped head where the humerus capitulum attaches. Medially you will see an ulnar notch. This ulnar notch will attach with the ulna, and this joint is known as pivot joint. You have been taught joints. So this is a pivot joint. And in the lower end also we are having a ulnar notch which will attach with the lower end of the ulna, and there will be another pivot joint. And in between that, why this is called the interosseous, interosseous border? Because between the radius and the ulna, this space, the lower 3/4, there will be a membrane which is known as the interosseous membrane. What is a membrane? A membrane is just a film-like structure, a simple film-like structure. This will be the interosseous membrane. Let me show you. See, this thing will be the interosseous membrane, this portion. If you see the muscle structures, in between these muscles there will be a membrane-like structure, whitish structure, which is mainly the interosseous membrane. And this is the interosseous border, and this is the ulna. Okay. And let us also see this bone. If we isolate the radius, see, this is the radial articular fovea, and this is the head of the radius which usually articulates with the capitulum, and this is the radial tuberosity as I have said, and this is the anterior border, this is the surface, anterior surface, this is the interosseous border, and this is the lateral surface. And then we'll come to the lower end. This is the styloid process, and this is the ulnar notch. The ulnar notch I was talking about. This is the carpal articular surface for lunate. So we are having 8 carpal bones which will be taught. So this is the articular surface for lunate specifically, and another one we are having for capitate. Scaphoid. So scaphoid is also a very important bone, because whenever any carpal bones get fractured, usually the scaphoid is a very important one, because usually avascular necrosis occurs with the scaphoid. You don't need to just listen these things. The scaphoid bone usually undergo avascular necrosis. What is avascular necrosis? Necrosis means the bone will die. Okay, the blood supply will die due to avascularization. Because of what? Because the bone will be broken, so the blood supply will not reach evenly to all the portion of the bone. So this will result in necrosis of the bone. So this thing you just remember. I have told this thing. Now the upper end, as I have said, it consists of a disc-shaped head, neck and tuberosity. This one is the tuberosity. Neck is this constricted region, and this one is head. This part constitutes the upper end. Okay. This is the upper end, the head, the neck and the tuberosity, radial tuberosity. Okay. Medially it articulates with the ulnar notch. Remaining part is enclosed by the annular ligament. I will show you this thing. The constricted region just below the head is the neck, as I have said. Below the medial part of the neck is the radial tuberosity. The tuberosity is rough posteriorly and smooth anteriorly. So see, this is the radial tuberosity. So it is rough posteriorly. This posterior part, this is important because this is attachment for another muscle. This posterior part specifically, pronator teres attaches here, and this portion is smooth. See, this is the head of the radius if we see from this side. Okay. Now, just see, this is the ulnar notch to where the ulna has attached. Now the remaining 3/4 portion, this is annular ligament. Usually you will see this is cylindrical in nature in adults. Okay, cylindrical in nature. But in children, this is usually tubular in nature. So because of this what happens, a very serious injury known as pulled elbow occurs in children. Usually you will see that like parents usually hold their children like this and swung them like this. Okay, na? So due to this, they will not say that I have gotten fracture or I have gotten pulled elbow. They will just hold their hand like this and will cry. Immensely will cry. You just cannot move this hand. So this is usually case of pulled elbow, which occurs only in children because it is the annular ligament is usually tubular, is usually cylindrical, funnel shaped in case of adults, but in children it is tubular shaped. So the radius just slips out. This causes the dislodgement of the radius. Okay. Now the shaft. As I have said, the shaft has 3 borders and 3 surfaces. So this is the anterior border, this is the interosseous border, and besides we are having this one, this is the posterior border. Now between this anterior border and this interosseous border there is a surface. Okay, so this surface is the anterior surface. This surface between the anterior and the posterior we are having the lateral surface. And between the interosseous and the posterior, this posterior, we are having the posterior surface. Okay. See, if we cut the shaft like this, if we give an incision like this, not incision, just cut the bone like this, break in half, and then pull it like, see it like this, in this way, we will see this part. See, this is the sharp interosseous border as here. This is the interosseous border. You will see now, if you cut this part like this and break it in half, you will see this interosseous border, and this is the anterior surface. This is facing anteriorly. Okay, and this is the posterior border. This is the lateral surface. Just for understanding. Now the anterior border begins at the radial tuberosity and runs downwards and laterally across the anterior aspect of the shaft, as I have shown you. This is the anterior border coming downwards, and like here it like merges with the lower trunk. Like it becomes a bit smooth. Like it is not as sharp as it is in the upper end. Okay. And there is an anterior oblique line also. This one is the anterior oblique line. This oblique line is the anterior oblique line. Now the upper part of the posterior border runs downwards and laterally from the posterior part of the tuberosity, and the lower part of the posterior border runs downwards along the middle of the posterior aspect of the shaft of the lower end. Nothing about this, just see here. This is the anterior border, this is the posterior border. Just behind it, behind the tuberosity, a posterior border comes like this. You will see the sharp edge here. If you have the radius, the original radius bone in your home, you will feel it. Usually in the fiber, it is not appreciated. Okay, but in original bones, you can easily appreciate these things. Now the interosseous or the medial border is easily identified as it forms a sharp ridge which extends, as I have showed you, just below the tuberosity to the lower end of the shaft. Near the lower end, this border forms the posterior margin of a small triangular area. This thing. See, this is the interosseous border. This interosseous border goes downwards, and see, this is the triangular area. This is the triangular area of the interosseous border. The anterior surface, I have told about this. In the upper part of the bone, the lateral surface expands into a wide triangular area as it extends on the anterior and the posterior aspects of the bone. The lateral surface shows a rough area near the middle and the convex part of the shaft. So this is the lateral surface. See, there we cannot appreciate this thing, but sometimes in some bones you will see there is a small rough part in the lateral surface. Okay. Now the lower end, it is the same thing, the anterior, lateral as well as the medial surface, but along with that there is also anterior, posterior and lateral surface which continues same way as the shaft. Like in the shaft we are having these borders, surfaces. In the lower end also we will be having these surfaces, but along with that there is also a medial surface as well as a lower, this portion which is the Inferior surface. Okay. Now the lateral surface is prolonged downwards as a projection called the styloid process. This one is the styloid process. This sharp projection is known as the styloid process. The posterior aspect of the lower end is marked by a number of vertical groups. This thing is not important. There is only one group which is important, that is the dorsal group, narrow oblique group, like I have written somewhere, dorsal tubercle. See, this thing is important. This is the main thing here. This sharp part, this is known as the dorsal tubercle. See, these are the muscle insertions. So biceps brachii usually inserts, we are having some muscles which inserts in the radius bone and some muscles which originates from the radius bone. So origin means like these muscles begins their journey from this region only, and inserts means they have originated from some other place and inserts here. So basically we are having 5 muscles which inserts in the radius bone. Biceps brachii, which inserts in the rough posterior part of the radial tuberosity, this part. This is the radial tuberosity. In the posterior rough part attaches the biceps brachii. Supinator usually in the upper end of the lateral surface and extend. This is the lateral surface and in the upper end, and supinator inserts here and just gives like some fibers in the anterior as well as the posterior surface. Now the pronator teres inserts in the rough area on the middle of lateral surface. Like this is the lateral surface, in the middle of it the pronator teres inserts. Brachioradialis inserts in the lowest part of the lateral surface just above the styloid process. Here brachioradialis inserts. And pronator quadratus, it inserts in the lower part of the anterior surface and triangular area on the medial side of the lower end. So this is the lower end. On the medial side, pronator quadratus attaches like this. Okay. Now muscles origin. So 4 muscles originates from the radius: flexor digitorum superficialis, flexor pollicis longus, abductor pollicis longus, and extensor pollicis brevis. Now the flexor digitorum superficialis, it originates from the upper part of the anterior border. So this is the upper part of the anterior border. This is the anterior border. And in the upper part of the anterior border, in this oblique part, the flexor digitorum superficialis originates. And the flexor pollicis longus in the upper 2/3 of the anterior surface, it originates. And abductor pollicis longus in the upper part of the posterior surface. Extensor pollicis brevis, this muscle originates from the small area on the posterior surface below the area for adductor pollicis longus. See, this is the radial tuberosity where biceps brachii inserts, and this is the supinator. It attaches, like inserts in the lateral surface and gives for some fibers anteriorly and some fibers posteriorly. And this is flexor digitorum superficialis in the anterior oblique line. So this is the anterior border, it goes downwards like this, and this is the flexor digitorum superficialis, it inserts in the upper 2/3 of the anterior border, anterior oblique line. And flexor pollicis longus, it attaches, inserts in the medial surface. In the lower surface, in this surface, pronator quadratus, it inserts. And in the small portion just above the styloid process, the brachioradialis inserts. And this is the posterior portion of the same bone. This is the right radius and this is the posterior portion. So you can see the supinator has also gone posteriorly. This is the abductor pollicis longus, this is extensor pollicis brevis, and this is the capsule of wrist joint. So basically in the wrist joint we are having the carpal bones. So these carpal bones form the wrist joint, and it is having an a capsule which just so this is the capsule of the wrist joint, and in this capsule all the carpal bone attaches like this. There are 8 carpal bones, this attaches like this, and we have seen that scaphoid and lunate also have their relations to this bone on the inferior surface. That is what I have told you in the beginning of the class. Okay, so basically this is the radius. So in radius, in the front, see posteriorly you will see nothing, like this is very much smooth. Okay, anteriorly there is an anterior oblique line. This is the medial interosseous border. So these are the rough surfaces. So in this way you can know that this is the front side, and the radial tuberosity will always face medially. Okay. So this is the left side. So if you do it like this, now the radial tuberosity is facing laterally. Styloid process is also in the below. So you can say that this is right side, but this is not right side because you are not having this anterior oblique line. It is smooth. So in this way, but in exam you can just hold it like this and see this is the smooth surface, and behind it is the rough surface. So this is facing anteriorly. Now radial tuberosity is facing medially. So this is the left side. Okay. Now there are certain other attachments, you just need to know these things. So the articular capsule of the wrist joint, it has attachment for the anterior and posterior margins of lower end of styloid process. So this is the articular capsule of the wrist joint that I have shown you in the picture also. Now there is also an articular disc of inferior radioulnar joint. So this is the radioulnar joint. Here, this is the superior radioulnar joint, this is the inferior radioulnar joint. This one. This is the inferior radioulnar joint, this is the superior radioulnar joint, and this is the interosseous membrane as I have told you. So, in the articular disc of the inferior radioulnar joint, the lower border of the ulnar notch attaches. And the interosseous membrane is also another structure where lower 3/4 of the interosseous border attaches. As I have told you in the beginning only, that the interosseous membrane usually completes the lower 3/4. The above 1/4 it is blank. Okay. Then there is an oblique cord just below the radial tuberosity here. Here there is an oblique cord. You will not appreciate in this bone. In some bones you can appreciate it properly. And extensor retinaculum has attachment for the lower part of the anterior border. Now the lower end of the radius, there are certain tendons which are related to this thing. There is a groove behind the medial part of the lower end. So this is the lower end, and this is the medial part. Just below the medial part of the lower end, this portion, extensor digitorum and extensor indicis, these things will seem alien to you because as we go through your full anatomy curriculum, you will know this thing. Extensor means always these muscles which helps in extension. Okay, flexor always helps in flex. So this is flexion. So all these muscles will have their name with flexor, and behind these are called as extensors. Similarly here also, in our lower limb the opposite thing happens. Front side we will see because the during like embryology portion you will see it rotates like this. So the front side becomes extensors and the behind part becomes flexors. So you will see that we usually bend our knees like this but flex our elbow like this. Okay. So the groove behind the medial part of the lower end, extensor digitorum and extensor indicis, these tendons are related. And there is an oblique groove medial to the dorsal tubercle. So this is the dorsal tubercle. Now just medial to this, extensor pollicis longus, another muscle of the posterior part of the forearm, attaches. And groove lateral to the dorsal tubercle here. This is the groove. Now this is lateral because like this is lateral. So here extensor carpi radialis longus and brevis, these tendons are related. Now the lateral aspect of the lower end of the radius is crossed by the tendon of the abductor pollicis longus and the extensor pollicis brevis. We will see these things. Now ossification. What is ossification? Anyone of you know? Yes. So basically there are two ossification centers. One is primary center and there are two secondary centers. Basically the primary centers form in utero, like it appears in the shaft during the 8th week of fetal life. And there are two secondary centers. In radial tuberosity also occasionally some centers ossify, but it is like a rare thing to see. But the secondary center appears in the lower end in the first year and joins the shaft during the 18 years of age. So basically you are having it joined. So then there is secondary center appears in the head of the bone during the 4th or 5th year and fuses with the shaft around the 16th year. So basically we think that we are adults, but there are certain bones in our body which hasn't ossified till date also. Okay, for example, pisiform ossify at 12 years of age. We will see these things. Now certain clinical anatomy portion. So subluxation of radial head, also known as pulled elbow. As I have told you, in children what happens, the thing is like tubular in structure, the annular ligament, and like a concave funnel shaped structure in adults. So whenever the elbow is pulled like this, stretched like this, the elbow slips out. So this is pulled elbow. Then Colles fracture. Colles fracture occurs due to fush. Anybody knows what is the mnemonic for fush? No, na? So yes, this is called fush. So this is fall on outstretched hand. So if someone falls like this, usually in the case of children it occurs. So if someone falls like this is an outstretched hand. So this portion will break out. Okay, the distal end of the radius will break out and dislocation will also occur. So it will result in something like this. You have seen fork, na, dinner fork. So exactly like this the hand will become. This will seem like a dinner fork. An opposite thing occurs in Smith's fracture. So it occurs in hyperflexed, like when the wrist is in hyperflexed position, this is flexion and this is hyperflexion. When someone falls like this, so this is hyperflex position. During this portion, the hand dislocates anteriorly and this portion, lower part of the hand, dislocates posteriorly. So due to this, it appears to be like the shape of a garden spade. Like this is like a spade, so it appears like a garden spade. Then weight transmission. So basically, whenever a person falls, all of the weight like is transmitted to this region. So you will see that whenever someone meets an accident and fall on this side, you will see the scaphoid bone will fracture, because it is the first thing that comes in like contact with the surface. And if the person is obese, so overweight, then also this thing will happen, that the whole weight will fall on this portion, and due to this the scaphoid bone will fracture, which further leads to avascular necrosis if proper care is not taken. So first of all, the weight is transmitted to this region, then it goes to radius. So in the lower end, the weight transmits to the radial end, radial end. This is the radius. So the weight transmits here, and just above this region in the elbow portion, mainly the ulna takes over. Okay, the weight is transmitted to the ulna, then it goes to the humerus, then to the clavicle, and in this way then to the ribs. So in this way what happens, whenever a person undergoes an accident and falls on an outstretched hand, usually the radius gets fractured before, then the ulna, then the humerus, followed by clavicle, and then ribs. Whenever the ribs get fractured, it is like the extreme thing. Now that's much.